Good morning. It's February 27th, 2025. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. Today we're broadcasting live spine surgery. Did you hit my arm? Did something hit my arm?
It was the card.
And our patient is having surgery on her neck, her cervical spine. Now she has a large disc herniation at C4-5, disc herniation C4-5. Her choices for surgery are anterior cervical discectomy and fusion versus endoscopic Duke laser disc repair. Those are really the most effective treatments in the world, or you can have an artificial disc put in, which is a metal disc, but I don't recommend those. They tend to pop out and have other problems. Now, she chose endoscopic surgery. So we're going to go in and remove the herniation without taking out the rest of the disc, and she will not need a fusion or any metal put in her neck. We're going to approach everything from the patient's left side. First thing I have to do is palpate the spine and then place the needle. So I've got to do that. Her neck is supple, which is good. Henry?
Yes,
She's
sir.
not a neck pain patient, but let's show our audience all the different causes of neck pain. Shot?
Of course.
I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. All right, welcome back from our animation video. You can see there are about 30 things that cause neck pain, and each of them is a specific joint, the facets and the discs. And then there's fractures, tumors, infections, which are very rare. In her case, her symptoms are coming from a herniated disc, which is the most common cause of neck pain, and it can also cause compression of the spinal cord and damage to the spinal cord with dysfunction of the spinal cord called myelopathy, or radiculopathy, which is dysfunction or damage to the nerve roots coming off the spinal cord going down the arm. Shot. All right, so we're going to do a discogram. You guys see that x-ray there, Henry? Our needle is
Yes, we do.
Let's count. 2, 3, 4, 5. So we are at the 4-5 disc, C4-5 disc. Everyone agree? That is the proper disc for us to operate on. Yes, we all agree. We're going to do a discogram. Shot. There it is. Look at the herniation. Let me do a little more. Shot. All right, check this out, folks. This is amazing. Look at the dye, show the tear where the dye leaks out of the disc, and then it wraps around the herniation right there. You guys see the herniation?
Yes, we do.
That dye is wrapping around the back of the herniation so you can actually see the whole herniation. Perfect. We know we're at the right disc. She is intubated. She's asleep, totally out with a tube down her throat, breathing for her. And This surgery will take about 30 minutes. We're going to go endoscopically through a 4mm incision. So why don't more surgeons do this? The answer is they don't know how. They don't have the training, they don't have the equipment, they don't have the staff to do it. Duke Spine has been doing these endoscopic surgeries for 19 going on 20 years. We've placed the needle, we placed the guide wire. We're going to take the needle out and leave the guide wire. Jordan, show the audience the endotracheal tube on the lateral view, and there's the endotracheal tube. It's a solid line, and the esophageal temperature probe, which is in the esophagus, is a braided line. Okay, we made a 4mm incision. I'm now going down to the disc using a dilator, which is a skinny little metal pencil that slides down the guide wire. And the nice thing, look, we're not cutting any tissues in her neck. There's no cutting like with an ACDF or spinal fusion or artificial disc. There would be a big cut on her neck. She would have trauma to the soft tissues. She would have swallowing problems, scar tissue, hoarseness, all that could be permanent. With this surgery, we're not cutting anything. We're not damaging any tissues. Everything we're doing is minimally invasive. And look, 1 drop of blood for the whole surgery. We're going to get an AP to see where we are. We want to be as close to the middle of the disc as we can be. That's perfect. We are exactly dead center. By the way, Jordan, show everybody once again. Show them the endotracheal tube. Yep. And the esophageal temperature probe. Yep. Now show us the disc that we're working on. Yes. Show us the tears on both sides. There's the tear on the left. There's a tear on the right. And the dye is leaking out. And the herniation is in the middle. Just to her right. All right. Any questions? Type them up. In the meantime, Henry's going to show you how does a herniated disc cause so much pain for a patient.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. You can see how a posterior annular tear in the wall of the disc is what lets the herniation out. Sean, we are almost in perfect position with our tube. I'm just advancing my tube to the best position, right at the back of the disc. I think that's going to be as good as I can get it. Now, we can remove the herniation now. Show us the tube. So, you guys see the tube right there that goes through the disc?
Yes, we do.
And to the back. Now, the herniation is just there, and we're going to use the laser to remove that herniation, and we're going to leave the rest of the disc alone. Any questions?
Yes, we have a question coming from Lanu on YouTube.
Hi, Lanu. Welcome.
Asking, her herniation is deep despite of her young age. Do you know what happened to her?
Trauma. We don't know the exact reason, but all disc herniations come from trauma. So some type of an accident. In her case, I don't want to comment because I don't have the information right now, what caused her trauma, but some type of trauma. All right, here we go. This is a beautiful surgery. It's outpatient. There is no hospitalization. It's one of the reasons the hospitals don't like us. You ready? And it's also doesn't use any metal or implants, which is the reason why the implant companies don't like us. And it's not performed by other surgeons because they don't know how to do it. It's a very technical, very difficult surgery, and that's why they don't like us. So we have a lot of people that don't like us because they don't do the surgery and they don't benefit. But patients benefit because the patient doesn't have to have metal put in their neck. I'm not getting much from the laser, I don't think.
Maybe 20?
There's definitely something happening.
Right? It's 550. 550. The box. It's on the second
Yeah, for those of you who are wondering how,
You don't feel it.
for those of you who, it's new? This is new?
Well, this one is a new one, but we used this before. So. Try like
All right, well, let's just see. That's better right there, so let's keep an eye on it. That glass fiber you guys are seeing in the picture at 12 o'clock, that is the laser fiber. It delivers the laser energy from a laser machine here in the operating room called the Holmium YAG laser. It's a medical laser, FDA approved for this procedure. And, oh, look at that herniation right there. It's a big one. We're going to be pulling out about 30 of these pieces of herniation.
Thank you.
Thank you, Luis. That was a good one. You guys want to see that?
Yes,
Now, it looks big, but it's not really that big. It's about 3 millimeters. Can you see this, Henry?
Yes, we can.
So there it is. That's one piece. There's the measurement right there. You can see it's about 3 millimeters. So the herniation she has is made up of about 30 pieces like that. Some will be bigger, some will be smaller, but it'll be a variety of sizes. And the problem is, as long as there's a tear in the back of the disc, she's going to keep making herniations. So our goal here is clean this up so that the disc will heal itself. That's why we call it the Duke Laser Disc Repair. We use the laser to debride the tear, get rid of the herniation that's there, so that the disc will actually heal itself. If you have questions, I'm happy to take them. Once again, that fiber that I was pointing out right there, that is 1/2 of a millimeter. It's 0.5 millimeter, just to give you an idea of the precision of this surgery, how precise it really is. It's extremely precise. I'm just adjusting my focus to improve it. We're using a camera and an endoscope. So this is endoscopic spine surgery. We are at the back of the disc at C4-C5. That's what the tube is. You see the metal tube that looks like a circle?
Yes, we do.
That metal tube is made out of stainless steel, surgical stainless steel. It's made in Germany. It's FDA approved. And oh, look at that piece of herniation that just came out. That's one of the pieces of herniation. Guys, see that?
Yes, we do.
Pretty damn cool. So we're going to be releasing a bunch of these. This is a gigantic herniation. Now, if you think about that fiber is 1/2 of a millimeter wide, then you can see the effect of the laser on the tissue. Whoa, there's another piece right there. The effect of the laser, when it blasts the tissue, you guys can see that there's actually, you can imagine that that's about 1/20th of a millimeter effect. So the laser is the most precise tool in medicine. With a precision used endoscopically, like I am, a precision of 1/20th of a millimeter. Now there's nothing in medicine. Oh, there's another herniation, a big one. Right there. You guys see it?
Yes, we do.
All right. Why is the irrigation changing so quickly? Oh, so you feel one level small bag. I see. All right.
Yeah, we are saving the.
You're saving the big bags.
Yes.
All right. So I couldn't grab it out. I may have to just break it up into smaller pieces. Let's see. Any questions?
Yes, we have another question coming from Lanu once more on YouTube,
Thank you, Lanu, for keeping me entertained.
asking, does she have numbness on her hands? Just curious because
She had numbness in her hands, yes.
Okay.
That's exactly right. So what causes the numbness in the hands with a cervical disc herniation? Two things. Pressure or irritation on the spinal cord, pressure or irritation on the nerve roots. Either one could cause the numbness in the hands. In her case, I believe it's the spinal cord because the herniation is more to the right and it's center right. Center is spinal cord, right is nerve root. And to get both hands, it would have to be the spinal cord affected that causes the both hand symptoms, okay? So there's another piece of herniation right there coming out. So all of these pieces of herniation I'm releasing with the laser are floating out through the tube. Remember, this tube is 4 millimeters. That's tiny. That glass fiber you're seeing, the fiber optic fiber, is 0.5 millimeter. So we are removing these pieces of herniation through the inner diameter of the tube at 2.8 millimeters. So it gives you an idea of how big these pieces are, right? They're not big. I think that's a big piece of herniation right there. We're going to find out in a moment.
And at this moment, no current questions.
Well, for that, if that's the case, we've already shown the 30 causes of neck pain.
Yes.
Correct?
Correct. And how it is, what causes neck pain, and how it is that we cure it. So we can talk about the second most common cause of neck pain, which is the facets.
It's a great idea. We're going to show you. She doesn't have. We don't think she has facet pain. We're not treating it. But the second most common cause of neck pain is facet joint inflammation or inflammation in the facet joint. Again, there's another. These are all pieces of herniation. Remember, I told you there'd be about 30. That's our average. What we see is around 30. Facet joint inflammation is a result of trauma to the facet joint. It happens at the same time the patient has disc trauma, disc injury. Trauma to the spine always affects the disc and the facet, both. But that doesn't mean the patient will have symptoms from both. The patient may only have symptoms from the disc or the facet. Most commonly, symptoms are from the disc. 90% of patients with neck pain, that's chronic, meaning more than 6 months, more than 6 weeks, 90% of those patients are going to have their pain coming from a damaged disc, which you guys just saw the video on. But 10%, that's the primary cause of pain. The main cause of pain is the disc. But about 10% of those patients, the main cause of pain is not the disc, it's the facet joint. All right, you guys see what I'm working on here?
Yes, we do.
Just to help you understand, the spinal cord is just to the right of where I'm operating. I'm cutting the pieces of herniation, I'm vaporizing them with a laser. Now, there is no tool in the world that is as good as this laser right now doing what I'm doing. The spinal cord is literally millimeter, not even a millimeter, 0.5 millimeter away. You guys see that? That's the spinal cord right over there. We want to avoid that area. People ask me, are there risks to the surgery? Absolutely. We're operating on your spine next to your spinal cord and nerves. There's always risks, vascular injury, neurological injury, infection. But in 19 years of doing this surgery, we've never had an injury or a complication from this surgery. So It's a very safe surgery compared to like fusion. With fusion, whoa, piece of herniation. With fusion, the complication rate's as high as 50%. That's 50%. 1 out of every 5 patients will have a complication with fusion. And it's around 25% with artificial discs. At least that's what they report. I think it's higher than that. I think they hide the data because they don't want people being afraid of artificial disc surgery. But even at 25% of patients, that's 1 in 4 patients will have a complication from artificial disc surgery. That's high. Duke laser disc repair is 0. Currently 0%. Now, why is that? Because it's a safer surgery. But it's also because I'm a very good surgeon. My complication rate for fusion is 1%. So compared to the rest of the neurosurgeons out there who have a 50% on average complication rate, my fusion complication rate is 1%. My artificial disc complication rate is 0. My posterior cervical laminectomy and fusion complication rate is around 3%. The average is around 30% for the other surgeons. All right, point is, this is a very safe surgery, even when you're operating right against the spinal cord. Why? Because the laser is so precise, and you can actually see what you're doing. All right, Luis, let's see what we got here. I know there's a big herniation right here. You can kind of see it right there. Where it tore through. You guys see the tear? The blue tear?
Yes, we do.
That is the tear, not through the annulus. We're already past the annulus. That is a tear through what's called the posterior longitudinal ligament, the PLL. That's in the back of the disc. I'm going to cut the rest of the PLL so I can get the herniation out. You guys see this? It's called the PLL, posterior longitudinal ligament. Now, most disc herniations are superficial or towards me of the PLL. They don't go through the PLL in the cervical spine. But this one has blown right past the PLL because the trauma was so significant that it went right through the PLL. I would say 90% of disc herniations in the neck do not go through the PLL. This one clearly did. You see it right there, the blue herniation? That's one of the reasons we use our dye, is so I can see the herniation. You can trace it and find it. This is as hard as it gets surgery for laser for cervical spine, because this is a massive herniation sitting right on top of her spinal cord. All right. So far, everything's going well. I've got about 10 to 15 minutes left. Dr. B.
Okay, got it.
That's the foramen on the right side, neural foramen. I got about 15 minutes. So we're done.
She's doing great.
Yeah. This is a much more difficult surgery than our typical cervical herniation. Our typical cervical herniation is not as big, it's small. But I've got to go through that hole right there to get to the herniation. I got to make the hole wider, all right? Because you're not going to get the herniation out without making that hole a little bit wider. So let's go to it.
We have a couple questions.
Sure.
Next one coming from Lanu once more on YouTube asking.
By the way, look at the laser cutting this collagen. These are collagen fibers. I'm literally cutting one fiber at a time. That is 1/20th of a millimeter. Or basically 20 micrometers. Yeah, go ahead.
Lanu asking, a question for Henry. Are you allowed to touch the scope for maintenance or inspection? No. That is more in the hands of Louise.
Is Henry allowed to touch
the scope
the
for
the
maintenance
scope?
or inspection? That is more for Louise and Dr. Duke and everybody else around there that is capable of maintaining that. But for me, it's I just try to make sure that it is for the endoscope for you to see on here. That is my responsibility for that. But for maintenance inspection, no. And then next question is coming from Charlie on YouTube.
Charlie?
Yes,
Hi,
correct.
Charlie. Welcome.
Asking, have you ever had a patient with cervical disc problems that seem to be causing a feeling of pressure on the side of the head and or ear with tinnitus?
Well, so people ask me these questions about tinnitus all the time, and the answer is, can a herniated disc cause tinnitus? I guess it can. It's not a common symptom, but it is certainly possible. I wouldn't rule it out. So the answer is yes, but if you want to know if yours is causing your symptoms, you need to do an MRI review with me so I can actually see you and figure out what's causing your symptoms. Because there's other things that cause your symptoms besides herniated disc. Tinnitus, which is ringing in the ear, is a very common symptom, and 9 out of 10 times, or 90% of the time, it has 95% of the time, or 99% of the time, has nothing to do with the spine. All right, so to blame it on a problem with the spine it's what we call a diagnosis of exclusion. You would want to rule everything else out that normally causes tinnitus. All right, my God, what a herniation. By the way, see this here, the edge right there? That's the back of the vertebral body. So all this herniation is past the vertebral body, way past it. This blue stuff normally lives way up here, but there was a tear from trauma, and it squeezed out, and it's literally sitting on top of the spinal cord. And we're literally shelling it out. Just a millimeter, not even a millimeter, a 20th of a millimeter at a time. So I got to remove more of the PLL over here.
We have a couple more questions.
Yep.
Next one coming from Smarzig on YouTube.
Uh-huh.
Asking, besides the surgeries that your clinic is doing, what other parts of the body would your technique be used for?
Wow. Well, Smarzig. The Duke laser disc repair is used for only one thing: herniated discs, bulging discs, degenerated discs, all right? Spine. The Duke plasma rhizotomy is used for the spine, for painful facet joints, the SI joint, the piriformis, not the piriformis, the SI joint, the facet joints, the shoulder, the knee, the hip, okay? By the way, that is the spinal cord right there, and we are operating right next to it. There's a bone spur here. I just vaporized. I got to figure out how much more of this I can take. Look how precise this is. This is the most precise tool in medicine, the laser. As long as you use it the way I'm using it, with the endoscope, where you can see. Huh? Fine. Anybody know the trauma history for this patient? Lifting. All right. Well, I can tell you right now, this herniation is not recent. It's all calcified. That's what the gold color is.
Heavy work sometimes.
Huh?
The restaurant industry can be heavy work, bar and restaurant.
Yeah.
Nice. Bottles.
Yeah. This is probably the hardest one I've ever taken out in my entire career.
Really?
Yeah. Because this is an old part of the herniation. This is not recent. And it's literally dug in. That whole indentation is the spinal cord indented. The question is, how much more medial can I go? I think we've gotten about 70% of it out so far. And remember, you can never get 100%. For those of you who watch my surgeries, I always say the same thing. We're never going to get 100%. We need to get enough of this out to get rid of her symptoms and take away her risk of basically spinal cord injury or reduce it massively. That's probably as much as I'm going to get. What's left is just a shell, and it's really not pushing anymore on the spinal cord. That said, I want to check the other sides and check the foramen. Make sure we get all the herniation out of the foramen. This is, a level 10. This is a level 10 in difficulty. I got 2 minutes left. A level 10 in difficulty. No doubt about it. This is the hardest herniation I've ever taken out endoscopically in the cervical spine. And it's because it's calcified partially. It's not completely calcified, but it's got a lot of calcium in it. It's not a calcified herniation in the sense of it's solid rock that we see sometimes, but it's got a lot of calcium in it, meaning it's been there for a long, long time. Now there's still some more herniation here I want to get out, but we're just about done with her surgery. This is a newer herniation. See the blue? But then, oh, look at that. That's beautiful. So we got a big herniation over here too. A lot of times the MRI won't show everything because, well, the MRI was done a few months ago, right? So people's disc herniations are dynamic. They're not static. You don't get a herniation and you're done. They keep herniating. So from the time of the MRI until now, she may have herniated more. And that's what I'm seeing. It looks like there's more herniation. Any questions?
Yes, we got a good amount of questions. Next one is coming from Izod on YouTube.
Hello, Izod. Welcome.
Saying, is there any possibility that one has myelopathy, but he does not have any symptoms like neck pain and numbness? Will you still think that to be treated through DLDR?
Yeah. Great question, Izod. Very smart question. So what Izod's asking is it possible for patients to have myelopathy, which is spinal cord dysfunction from pressure on the spinal cord or inflammation on the spinal cord? Is it possible to have myelopathy without the patient having any symptoms? The answer is yes. Myelopathy is not just based on symptoms, it's also based on exam findings, what the doctor finds on exam. Myelopathic findings include balance trouble, so the patient may sway during the exam. It includes weakness, clumsiness of the hands. You can have atrophy of the muscles from myelopathy if it's long-standing. So I look at the intrinsic muscles of the hand on the back of the hand. Is there wasting of those muscles? I look for reflex changes like increase in reflex. I look for Babinski's. I look for clonus. I look for Romberg. These are all indicate, oh, sweet Lord Jesus. You're accident prone. All right. So these are all findings on exam that the patient is not going to be aware of them because they don't know how to do a neurological exam. But I will find those things. So brisk reflexes, muscle atrophy, spasticity, and Romberg, clonus, things like that. There's lots of things. And so we can show myelopathy on exam even though the patient has no symptoms.
You have about 5 minutes?
No, I'm done. Oh, that was a big herniation. I'm pretty much done.
Okay.
I've peeled away as much as I can safely off the spinal cord. I've gotten rid of all the other loose herniations. I'm just taking one more look because sometimes you look away and there's something else that just pops out of there. This is another piece of herniation. It's almost too big to come out, so I'm going to try to grab it. We'll see if I can. Otherwise, I have to bivalve it with the laser, cut it in half, and then take the two halves out individually. Oh, there it is. So that's a good piece. We've gotten a lot of good pieces. Luis will start to put those pieces together over here so we can get a family photo at the end. Any questions?
Yes.
We're
Next.
about to be done.
Next question coming from Pavel on YouTube.
Hello, Pavel.
Asking, hypothetically...
I just want to know one thing. Does Pavel live in a hovel?
That's a great question. We'll see what he says after.
All right, go ahead.
Asking, hypothetically, if you ever needed a disc repair, who would you trust to do the surgery? Again, amazing to watch what you do.
Yeah, I would not trust anybody in the world to do a disc repair because I'm the only one doing them. So there is nobody. But if I had life or death, I would probably have Luis do it. If I had to trust one person, maybe Luis and Dr. Patel. And I would pray to God. And maybe soon, if you ask me the same question at the end of summer, this summer, I'll have a different answer.
I would do your anesthesia.
Berndes says he'd do my anesthesia. Thank you, Dr. Berndes. But at the end of the summer, I'll have a different answer. The name will be Arias Duke-Majan, my son. He will be here this summer, and he's going to learn how to do these surgeries with me. I told him, you better learn before I die or become incapacitated. We never know our plans in life. I hope that doesn't happen, but we just never know. I'm going to take a little more peek here because I'm seeing more of this herniation that I can get out. And that's the key, is really just being super careful because we're right on top of the spinal cord and I don't want to do anything bad. I don't want to have a complication, but I also don't want to leave any more of this stuff than I have to. Great question.
Next question coming from Charlie, once more on YouTube. Asking, what triggers the energy release from the laser when you want it?
Oh,
Finger
great
trigger,
question.
foot pedal, other?
Yeah, Charlie, it's a foot pedal. My right foot. My right foot is stepping on a pedal right now, releasing or turning on the laser. It's a foot pedal. Great question. Never talked about that before. Yep. This laser has a foot pedal, so the surgeon can actually push on the foot pedal and turn on the laser. Yeah, we're almost done. I thought we were done, but I'm finding that I can get more of this. This is just literally a crazy, crazy herniation. Why is this so crazy? One, it's humongous. Number two, most important, it literally went past. See, all the herniations we typically take out are right here. They're they're inside the annular tear and just outside the annulus, but they're above the posterior ligament, which is behind the annulus. This one went beyond the posterior ligament. It tore through it. And that's what I've been removing right there, little bits of that PLL. Those are PLL right there. And look what I'm finding behind it. Herniation. So I've got to take more of this out. It's safe. That's why I'm doing it. If it wasn't safe, I wouldn't be doing it. But it's safe. But you guys can see the difference, right? This is spinal cord right here, the white, and then here's herniation. It's blue. That's why we use the Duke Spine blue dye. Duke Spine dye is so I can see the herniation. If I didn't inject that dye, guess what? This would all be the same color. It would all be white. That's crazy, huh? So the dye allows me to find the herniation and remove it properly, safely. All right, we're just about done. That's amazing. I can't believe how much I actually got out. I'm really pleased. Dr. B, I'm sorry I lied to you and told you it would be 5 minutes when it's actually 10 minutes. So,
I'm very flexible lectures.
yes, you are. All right, any more questions? We're just about done. Again, oh, beautiful. Look at that piece. Look how calcified it was. Huh? That was a good piece. And Luis is, are you getting some pieces together?
Well, the other one I said they ready.
Oh my God, Luis, how could you? How could you? I'm just kidding. I'm just kidding. Guys, we're done. This is it. I just went out the other foramen. Look at that. Amazing. This is truly incredible, huh? Oh yeah, she's going to do so good. She's going to do so good. I mean, honestly, no surgeon could peel off that herniation off the spinal cord like I just did with the laser. It's impossible. Done.
Sitting on, please. Thank you.
All right. This is the best surgery in the world for a herniated disc in the neck for a patient. Not good for the other surgeons because they lose business. Not good for the hospitals because they lose business. Not good for the companies that make the metal and plastic they put in your neck and promote all those garbage to be put in. Not good for them. This surgery is only good for the patient. Actually, it's good for the insurance company too, but they're too stupid to understand that. They don't listen. Check this out, folks. By the way, Luis already sent, okay, I want to show you a few things. One, look at this tube. This tube is the tube I did the whole surgery through. See how small it is? 4 millimeters. Put that down. Oh, sideways. Other way. Yep. 4 millimeters. You guys see that?
Yes, we do.
Second of all, go ahead, take it away. The herniation that we took out had about 25 pieces. And here's a few of them. Luis already sent a bunch of them off to the pathologist to look at. But yeah, 25 pieces. And here's your incision. Okay, right there, 4 millimeters. Guess what? We lost 1 drop of blood the whole surgery. 1 drop. So, if you love yourself, don't go have surgery anywhere else. Come to Duke Spine. We'll fix it for you the right way. All right, Henry, any other questions?
Just one final question coming from Izod once more on YouTube, asking, if there are 2 out of 3 discs affected, would there be a single session/procedure for 3 discs, or you will carry out the DLDR separately?
Great question, Izod. We do, for sure, we do multiple discs in one session. I'm the first in the world to do that. When I learned endoscopic surgery from the Koreans, Dr. Sang-Ho Lee and Dr. Gun Choi, over in South Korea at Woodall Hospital, he was the first to do endoscopic cervical transdiscal surgery like I just did. And Dr. Sang-Ho Lee would only do 1 disc at a time. But I developed a technique to slide along the front of the spine up and down to get all the discs treated. We can treat up to 4 discs in one surgery, 4, which is really all that goes bad in your neck. All right, any other questions?
That is it. No current questions.
Thanks for joining us. It was an amazingly successful surgery. I got 90% of the herniation out. You only need about 50% to get symptom relief, but we got more. We got as much as we could, and I felt really good about that. This is going to be one of our best surgeries. Henry, flag this as a teaching case.
Of course.
Teaching case. And put it in the file as a teaching case for cervical DLDR.
You got it.
Thanks for joining us. We'll be back. Our next patient is having the SI joint and the piriformis muscle release because they're having back pain. So we'll be back in about 30 minutes.